The fear model is assumed to be relatively impenetrable to other models with which it lacks to direct connections, and so will tend to run its course once activated with few possibilities that other processes can stop it. Even though the fear model is relatively impenetrable to conscious influences, Ahman and Minica argued that the fear model itself can have a profound influence by biasing and distorting conscious cognition of the threat stimulus. In support of their contention of the independence of the fear model from the influence of conscious cognition, Ullman and Vines cite evidence that 1. Masking of stimuli affects conscious appraisals but not conditioned responses. 2. Instructions that alter explicit UCSCS expectancies do not affect conditioned response to biological fear-relevant stimuli. 3. Individuals can acquire conditioned fear responses to masked stimuli outside conscious awareness. And 4. Conditioned fear responses to masked stimuli can affect conscious cognition in the form of expectancy judgments. A final characteristic is its specific neural circuitry. Ahman and Minica consider the amygdala the central neural structure involved in the control of fear and fear learning, and contend that fear activation occurs via Liddell's subcortical non-cognitive thalamo-amygdala pathway, whereas cognitive learning occurs via the hippocampus and higher cortical regions. The authors contend that the amygdala has more afferent than efferent connections to the cortex, and so has more influence on the cortex than the reverse. Based on this view of the neural structure of the fear model, they conclude that 1. Non-conscious activation of the amygdala occurs via a neural route that does not involve the cortex. 2. This neural circuitry is specific to fear, and any conscious cognitive processes associated with fear are a consequence of the activated fear model and thus play no causal role in fear activation. Thus, biased appraisals and beliefs are a product of automatic fear activation and the product of psychophysiological and reflexive defensive responses. Exaggerated beliefs in danger may play a role in maintaining anxiety over time, but they are the consequence rather than the cause of fear. In cognitive therapy for anxiety and depression, patients are taught a very basic item. The way you think affects the way you feel. The simple statement is the cornerstone of cognitive theory and therapy of emotional disorders, and yet the individuals often fail to recognize how their thoughts affect their mood state. Given the experience of intense, uncontrollable psychological arousal often present during acute anxiety, it is understandable why those who suffer with it may not recognize its cognitive basis. Notwithstanding this failure in recognition, cognition does play an important mediational function between situation and effect, as indicated in this diagram. Triggering situation: anxious thought appraisal, anxious feeling. Individuals usually assume that situations and not cognitions are responsible for their anxiety. Take, for example, how you feel in the period before an important exam. Anxiety will be high if you expect the exam to be difficult and you doubt your level of preparation. On the other hand, if you expect the exam to be quite easy or you are confident in your preparation, anxiety will be low. The same holds true for public speaking. If you evaluate your audience as friendly and respectful to your speech, your anxiety will be lower than if you evaluate the audience as critical, bored, or rejecting of your talk. In each example, it is not the situation, for example, writing an exam, giving a speech, or having a casual conversation, that determines the level of anxiety, but rather how the situation is appraised or evaluated. It is the way we think that has a powerful influence on whether we feel anxious or calm. The cognitive perspective can help us understand some apparent contradictions in anxiety disorders. How it is possible for a person to be so anxious over an irrational and highly improbable threat, and yet react with ease and no apparent anxiety in the face of more realistic dangers. What accounts for the highly selective and situationally specific nature of anxiety? Why is anxiety so persistent despite repeated non-occurrence of the anticipated danger?